So you finish a workout, grab a smoothie, and throw a banana in the blender.
So it sounds like a pretty standard morning.
Right. You drink it, toss the peel, and you probably don't give it a second thought. It's just, basic, mundane nutrition.
Yep, totally harmless.
But if you step out of your kitchen and into an emergency room, that exact same mineral is suddenly the primary ingredient used to instantly, irreversibly stop the human heart.
Which is a pretty terrifying pivot when you think about it.
It really is.
Yeah.
So we are talking about potassium today. Welcome to the Deep Dive.
Glad to be here.
Our mission today, for you listening, is to unpack potassium imbalance from like a clinical and nursing perspective. We're looking at this comprehensive medical text that covers the physiological first principles, the diagnostic cascades, the history, and really just how this one everyday electrolyte turns deadly.
Yeah, and while potassium imbalance might sound like standard dry textbook material, the underlying mechanisms here reveal a biological balancing act that is incredibly fragile. It's highly contested, it's easily misunderstood, and it really requires us to completely rethink what it means when a lab test tells you that your blood is perfectly normal.
Yeah, and that paradox you just mentioned is exactly where I want to start. Because to understand how potassium can stop a heart, we have to understand why doctors and nurses struggle to even measure it accurately in the first place.
It's surprisingly difficult.
Right. So the standard normal range for potassium in your blood, which is serum potassium, is usually listed as 3.5 to 5.0 milliequivalents per liter.
Exactly.
And if you drop below 3.5, you have hypokalemia. Go above 5.0, you have hyperkalemia. So on paper, it sounds pretty binary, like you're either in the safe zone or you aren't.
Yeah, but the problem with treating it as a binary is that the normal range is really just a population statistic.
Okay.
It's not this strict physiological cutoff that applies to every single human body in the exact same way.
So it varies from person to person.
Massively. A chronically ill patient, for instance, someone with long-standing kidney disease, they might walk around with a potassium level of like 5.8 for years.
Why?
And they might have zero symptoms, perfectly fine.
I guess because their body has had time to sort of adapt to that higher baseline over months or years.
Precisely. The adaptation is key there. But if you take a perfectly healthy person with a normal heart, and if their potassium suddenly drops from a 4.0 to a 3.0 in a matter of hours...
Like from a stomach bug or something?
Yes, severe vomiting or maybe a new diuretic medication, that rapid rate of change can trigger life-threatening arrhythmias.
Oh, wow.
So the absolute number on the lab report matters significantly less than the rate of change or, the patient's baseline kidney function.
Right. Context is everything. So let's unpack the math behind this, because there's a physical reality here that the sources highlight as a major stumbling block for medical students. And that is the 2% rule.
Right, the 2% rule. This is crucial.
Yeah, so when a phlebotomist draws your blood to check your potassium, they're only measuring about 2% of the total potassium in your body.
Exactly.
And the remaining 98% is just hidden away, like locked inside your cells.
Yeah, and that distinction changes everything about how we interpret lab results. The blood draw is only looking at the serum. It is an incredibly poor proxy for total body potassium.
It's basically like judging someone's entire net worth by only looking at the cash they currently have in their wallet.
That is a great way to put it.
Like, they could be completely bankrupt. Their total body potassium might be entirely depleted from weeks of illness, but the wallet looks full because they just went to the ATM.
Right.
The body just shifted whatever potassium it had left out of the cells and into the blood to compensate, just to keep the serum level looking okay.
Yeah, that analogy captures the illusion perfectly.
Yeah.
I mean, the body will fiercely protect that 2% in the blood to keep the heart beating, even if the cellular reserves are entirely empty.
That's wild.
And the deception actually goes both ways.
Yeah.
You can also have a terrifyingly high serum potassium reading that is completely fake.
Wait, how can a lab result be fake? Like, if the machine reads a high number, the potassium has to be in the blood, right?
Well, it is in the blood when the machine tests it, but it wasn't in the blood when it was actually circulating in the patient.
Oh, weird, okay.
This is a phenomenon called pseudohyperkalemia. So imagine the phlebotomist uses a needle that is too small, or they leave the tourniquet on the arm for way too long.
Okay, so a bad blood draw.
Right. The physical pressure and that tight squeeze can actually cause the red blood cells to physically rupture inside the plastic collection tube.
Oh, I see. And because 98% of potassium lives inside the cells, when those red blood cells burst open in the tube,
They spill all of their hidden intracellular potassium directly into the serum sample.
Wow.
So the lab machine analyzes the fluid and spits out a critically high panic value, but the patient sitting in the waiting room actually has completely normal circulating potassium.
Which means if a doctor or nurse just treats the number on the screen and aggressively lowers that patient's potassium, they could accidentally cause a fatal heart arrhythmia.
Exactly. It really highlights why you have to treat the whole patient, not just the lab value.
Man. But it also makes me wonder if measuring this stuff is so incredibly deceptive and tricky, how did we ever figure out its life and death importance in the first place?
It's a great question. And to understand that, we actually have to step out of the modern hospital entirely.
Okay, where are we going?
The origins of this discovery take us back to London in 1883. A British physician named Sidney Ringer was working at University College, and he was studying isolated frog hearts.
Isolated frog hearts.
Yeah, he was trying to figure out how to keep them beating outside of the body in a saline solution.
Which sounds like something straight out of a mad scientist novel, honestly.
I mean, it was pioneering physiology at the time. Ringer was meticulously testing different mixtures, but the real breakthrough came from a happy accident by his lab assistant.
Oh, I love a good lab accident.
Yeah, right. So the assistant was supposed to use distilled water to make the saline solutions, but instead they just used London tap water.
Wait, London tap water, which is notoriously hard water, meaning it's just full of minerals.
Exactly, full of calcium and potassium.
Ah,
And Ringer noticed that the frog hearts bathed in the tap water solution kept beating for hours, while the ones in the pure distilled water solutions died almost immediately.
that is incredible.
Yeah, so through trial and error, he realized that the heart would only maintain its rhythm if it was bathed in a very specific, delicate ratio of sodium, potassium, and calcium.
Okay.
If he added too much potassium relative to the calcium, the heart went completely flaccid. It just relaxed and stopped beating entirely.
So Ringer essentially founds electrolyte cardiology by accident in 1883.
Basically, yeah.
But the sources mention this massive gap in the timeline here. We used his mixture, what became known as Ringer's solution, for decades in medicine without actually knowing why it worked.
Yeah, the 70-year gap is one of the most fascinating delays in medical history, honestly. I mean, Ringer proved that the ratio governed the heart's electrical behavior through pure empirical observation.
Right, he saw it happening.
Right. But the scientific tools of the late 19th century were just not advanced enough to see the molecular machinery at play.
They didn't have the microscopes for it.
Exactly. The mechanistic explanation required the invention of better technology, and eventually, a Danish scientist named Jens Christian Skou in 1957.
Okay, so what was Scow looking at that Ringer couldn't see?
Well, Skou was researching crab nerve membranes, of all things.
Perhaps.
Yeah, he was looking for the physical engine that controls cellular electricity, and he ultimately discovered the sodium-potassium ATPase pump.
Okay, the pump.
Yes, this is an actual molecular machine that sits embedded in the membrane of almost every cell in your body. It uses one molecule of ATP, which is cellular energy, to actively trade 3 sodium ions out of the cell for 2 potassium ions brought into the cell.
Oh, so he found the actual mechanism that maintains that 98-2 ratio we talked about earlier.
He did, yeah. And it actually earned him a Nobel Prize in 1997.
Wow.
But the clinical bridge here is even more profound, because around the exact same time Skou was mapping the pump in Denmark, Willem Kolff was refining the artificial kidney.
The dialysis machine.
Right. So for the first time, doctors treating kidney failure patients who were dying because their bodies couldn't excrete potassium could hook a patient up to a machine, systematically scrub the excess potassium from their blood, and literally watch the patient's electrocardiogram, the ECG, stabilize in real time.
That must have been like magic to see.
It was. They were finally mapping Skou's invisible cellular pumps to the visual electrical tracings of the human heart.
And that connection brings us to the core of the clinical text, right? The cardiac cascade. Because once you know this molecular pump exists, you can understand exactly what happens to a human heart when that potassium gradient just collapses.
Exactly. And the foundation of that collapse is the resting membrane potential.
Okay, break that down for us.
So every single heart muscle cell, every cardiomyocyte, maintains a negative internal charge of roughly negative 90 millivolts at rest.
So the inside of the cell is deeply negative compared to the outside.
Yes. And that negative 90 millivolts exists almost entirely because potassium is highly concentrated inside the cell.
Right, like 140 milliequivalents inside versus just the 3.5 to 5.0 outside.
Precisely. You can think of it like a massive hydroelectric dam.
I like that.
Yeah, that steep gradient, that huge difference in concentration creates immense potential energy.
Right.
So when the cell needs to fire, it opens the floodgates, the ions rush across, and you get a crisp, clean electrical spike that travels in an organized wave across the heart, which causes a heartbeat.
But if the potassium outside the cell starts rising, like if the water level outside the dam gets too high, the pressure difference just drops.
Right. The gradient is compromised.
And this leads to a very specific sequence on an ECG that medical professionals have to memorize, right?
Yeah.
Because it literally predicts cardiac arrest.
Yeah. It's known as the hyperkalemia ECG cascade. As serum potassium rises to about 5.5 to 6.5, the first thing you see are the T waves on the monitor becoming incredibly tall and sharply pointed.
Okay, the peaked T waves.
Exactly. They call them peaked or tented T waves.
And if it continues to climb, hitting like 6.5 to 7.5, the sources say the P wave flattens out and the PR interval gets longer.
Right, because the upper chambers of the heart, the atria, are physically struggling to initiate the electrical signal.
Wow. And then at 7.0 to 8.0, the QRS complex widens.
Yeah.
And the QRS represents the main pumping chambers, the ventricles, right?
That's right. Because the electrical gradient is so severely compromised at that point, the electrical signal physically struggles to travel through the heart tissue.
So it's literally just moving sluggishly.
Exactly. It moves sluggishly. And because it takes longer to finish its path, it literally draws a wider, fatter line on the EKG paper over time.
That makes perfect sense. Like the
Yeah.
widening isn't just some random shape. It's a direct visual representation of the electricity slowing down.
Exactly.
And then if you go above 8.0 or 9.0, you get the absolute nightmare scenario. The widened QRS merges with the T wave into what's called a sine wave pattern,
Yeah, it just looks like a smooth, undulating wave on the screen.
which is terrifying.
It is. And within minutes, that usually degenerates into ventricular fibrillation or just flatline asystole.
So practically speaking, for the patient in the bed, does a medical team wait for the lab results to confirm this cascade?
Oh, they absolutely cannot wait.
Really?
Yeah, emergency departments treat a new peaked T wave combined with the right clinical context as a life-threatening emergency before the blood draw ever comes back from the lab.
Wow, just acting on the visual alone.
You have to. You cannot afford to wait 45 minutes for a centrifuge to spin down a sample when the electrical stability of the entire cardiac system is literally unraveling on the monitor in front of you.
It really emphasizes how fragile this gradient is naturally.
Yeah.
Which makes the hook we started with even more terrifying, honestly.
Yeah.
Because the starkest illustration of this system failing isn't an accident. It's the standard U.S. 3-drug lethal injection protocol developed in the late 1970s.
It is, yeah. The pharmacology of that protocol relies entirely on exploiting the resting membrane potential.
Right.
The third and final drug given is a highly concentrated solution of potassium chloride, administered rapidly and undiluted.
So it artificially drives the serum potassium up so incredibly fast that the heart's electrical conducting system is wiped out instantly.
Exactly. It induces massive hyperkalemia to produce immediate cardiac arrest.
Wow.
It is a dark but irrefutable demonstration of exactly what clinical teams are trying to prevent. And it is the precise reason why, in any hospital setting, IV potassium is classified as a high-alert medication.
Right, because of the danger.
A nurse will never, ever push undiluted potassium rapidly into a patient's vein. It is always heavily diluted and given slowly over hours.
That makes total sense. But intentional extremes aside, the sources also dive into how medications interact with this system in deeply paradoxical ways.
Yes.
Like the classic example in the text is the digoxin paradox.
Oh, digoxin is a venerable drug. I mean, it's been used for decades to treat heart failure and rhythm problems. And nursing students are taught very early on that if a patient is taking a daily dose of digoxin, having low potassium makes the drug more toxic and dangerous.
But then the text brings up research from 1973, Charles Bismuth's criteria, showing that in a massive acute overdose of digoxin, the strongest predictor of whether the patient will live or die is actually high potassium,
Right.
which feels completely backwards.
It does feel backwards, but the clinical data backs that up entirely. You just have to look at the mechanism to understand why the context flips.
Okay, so how does that work?
Well, digoxin works by actively binding to and inhibiting that very same sodium-potassium ATPase pump we talked about earlier.
Oh, so a normal dose of digoxin is almost like a minor traffic jam.
Right.
It slows down the cellular pumps just enough to help a failing heart contract a little harder and pump more efficiently.
Exactly.
But if a patient takes a massive overdose, they've essentially thrown a spike strip across a 10-lane highway.
Right.
Like every single cellular pump shuts down.
The pumps are completely paralyzed, so
Yep.
the potassium trying to get back into the cells just piles up in the bloodstream.
Oh, man.
The serum potassium rises sharply above 5.5, and the context totally flips from a low potassium problem to a high potassium emergency.
Wow.
And without administering the specific antidote, which is called DigiFab, to unbind the digoxin from the pumps, the mortality rate is incredibly high.
That is fascinating. And it's not just external drugs causing these extremes, right? Our own internal hormones play this game too, specifically the renin-angiotensin-aldosterone system.
Yeah, aldosterone is a hormone that tells your kidneys to hold on to sodium and get rid of potassium.
Okay.
So if your body develops a tumor that makes too much of it, a condition called Conn's syndrome, you end up urinating away your stores and developing severe hypokalemia. But if you have Addison's disease, where your adrenal glands are damaged and don't make enough aldosterone, your kidneys hold on to potassium, leading to hyperkalemia.
It all just comes back to that delicate balance.
Always.
Which brings us to perhaps the most unsettling part of the source material, honestly. The medical mirages. Because this balance is so precarious, our attempts to fix it in emergencies haven't always been perfect. Let's talk about the illusion of treatment.
This is a really important concept.
So when a patient comes into the ER with severe life-threatening hyperkalemia, the standard emergency code involves pushing high-V insulin along with glucose and sometimes giving albuterol, right?
Pushing calcium gluconate to stabilize the heart muscle directly so it doesn't fibrillate. Yeah.
Right, so the calcium protects the heart. But with the insulin and glucose,
Yeah.
wait, the sources say this doesn't actually remove any potassium from the body?
It doesn't.
So a medical team can run a code, give these drugs, the monitor goes back to green.
Yeah.
The lab says their potassium is normal, but the potassium's just hiding.
Exactly. We are essentially bailing water out of a sinking boat and throwing it into a closed cabin.
Oh, geez.
We haven't patched the hole, and we haven't removed the water from the ship. Insulin and albuterol simply rev up the sodium-potassium pumps, so they artificially force the excess potassium out of the blood and shove it temporarily back inside the cells.
You're just buying time.
You are buying maybe a few hours to protect the heart from that deadly ECG cascade.
Right.
But if you don't follow up with therapies that actually remove potassium from the body, like dialysis, diuretics, or gastrointestinal binders, that potassium will seep right back out of the cells into the blood, and the patient will be right back in lethal danger.
So how do we actually remove it? Because historically, the text points out that even our methods for removing potassium have been fraught with massive errors.
Yeah, they have.
Like the Kyaxylate disaster, for example.
Right. So introduced in the 1950s, sodium polystyrene sulfonate, known by the brand name Kyaxylate, is a resin you swallow. It binds to potassium in your gut so you can excrete it in your stool. And for over half a century, it was the absolute standard of care for chronic hyperkalemia, often mixed with a sugar called sorbitol to induce diarrhea and prevent constipation.
But from the 1980s onward, case reports started trickling in, linking this Kyaxylate-sorbitol combo to intestinal necrosis.
Yes.
It was literally causing the tissue of the bowel to die, especially in vulnerable patients who had just received kidney transplants.
And despite those early warnings, it took until 2013 for the FDA to issue a formal, rigorous warning about the risk of bowel necrosis.
2013.
Yeah. Clinical practice finally had to shift to newer, safer gastrointestinal binders like Pataromer. But it's a sobering proof that just because a treatment is considered the undisputed standard of care for 50 years doesn't mean it is perfectly safe.
Or free from devastating side effects.
Exactly.
It really forces you to question your assumptions.
And speaking of questioning assumptions, before we wrap up, the sources highlight some major misconceptions that still float around even among healthcare workers.
Oh, there are plenty. Let's do a quick myth-busting. Misconception 1. Bananas are the ultimate high-potassium food.
Culturally famous, yes. But nutritionally, they are entirely mid-tier.
Really?
Yeah, a medium banana only has about 400 to 450 milligrams of potassium. If you are actually trying to replenish dietary potassium, you should be eating potatoes with the skin on, white beans, spinach, or avocados. All of them significantly beat the banana.
Wow, good to know. Okay, misconception 2. High potassium always causes obvious symptoms like muscle cramps before it gets dangerous.
Dangerously false.
Yeah.
Many patients with severe hyperkalemia levels well above 6.5 or 7.0 feel absolutely nothing.
Nothing at all.
Or maybe just a vague, non-specific sense of fatigue right up until the exact moment their heart goes into a sudden, lethal arrhythmia. It is a silent killer.
Which is why routine lab monitoring is so critical. You simply cannot wait for symptoms.
Exactly.
For anyone listening who isn't running a code in an ER, this might feel a bit abstract, but the reality is that potassium imbalance sits at the intersection of almost every common chronic condition in modern healthcare.
Absolutely. Millions of people are taking medications every single day that alter this invisible gradient.
Right.
If you take an ACE inhibitor for your blood pressure, or an ARB, or a potassium-sparing diuretic like spironolactone, those drugs actively raise your serum potassium.
And if you take a loop diuretic, like furosemide, it actively flushes it out of your system.
Right.
So every time a doctor adjusts your meds, they're doing a complex potassium risk assessment in their head. It's the very reason they obsess over your routine blood panels.
It really is.
But beyond the medications and the ECG changes, I want to leave you with one final provocative thought from the source material to mull over on your own.
Oh, the interconnectedness of the human body goes far beyond just the kidneys and the heart.
Exactly. We didn't even have time to dive deeply into acid-base balance, but here is the core idea. Potassium and hydrogen, the tiny ion that makes your blood acidic, compete for the exact same doors into your cells.
Right. It's a constant microscopic trade-off.
When one goes in, the other has to come out to maintain the electrical charge. Think about the implications of that. A change in your breathing rate, say hyperventilating during a panic attack, alters the acidity of your blood.
Yeah.
And just by shifting the acid in your blood, you can literally alter the electrical charge of your heart, because your body will evict potassium from your cells just to make room to hide the excess hydrogen.
It's wild.
We tend to treat the body like a series of separate, neat compartments. You know, the lungs over here, the kidneys down there, the heart in the middle. But at the molecular level, they're all playing the exact same high-stakes game of musical chairs.
It's a beautiful, terrifying system. I mean, the flutter of a lung can dictate the rhythm of a heart.
It really is. So the next time you peel a banana or look at a routine lab report, take a second to appreciate that you aren't just looking at a mundane checkbox. You are looking at the raw electrical voltage that keeps you alive. Thanks for joining us on this deep dive.